In this lecture, we will look at other causes of restrictive lung dysfunction, including neoplastic cardiovascular, neuromuscular, and musculoskeletal disorders. The neoplastic cause of RLD is bronchogenic carcinoma or lung cancer. This is defined as malignant and abnormal growth of epithelial cells in the bronchus. Types include squamous cell, which accounts for 25 to 30% of all lung cancers, small cell, also called oat cell, which accounts for 10 to 15%, adenocarcinoma, which includes papillary, acinar, and bronchoalveolar carcinomas, which accounts for 40 to 50% of lung cancers, and large cell, which accounts for 10 to 15%. The most common cause for all types is cigarette smoking. Other causes are environmental exposures. Diagnostic tests include chest x-rays, PET and CT scans, which can show smaller lesions and metastases, bronchoscopy, transbronchial needle biopsy, thoracentesis, video-assisted thoracoscopy, and open lung biopsy. The three most widely accepted treatments are surgery, radiation, and chemotherapy. Newer treatments include immunotherapy, also called targeted therapy. Cardiovascular causes of RLD include pulmonary edema and pulmonary emboli. Pulmonary edema is increased fluid in the lungs due to either increased hydrostatic pressure, as seen in cardiogenic pulmonary edema secondary to left ventricular failure, or increased AC membrane permeability or non-cardiogenic pulmonary edema as seen in ARDS, allergic reactions, aspiration or inhalation injuries, drowning, etc. Diagnostics include blood tests for BNP, B-type or brain natriuretic peptide, chest x-ray, which reveals increased vascular markings in cardiomegaly, curly B lines or interstitial and alveolar infiltrates, pleural effusions or fluffy opacities. Arterial blood gases will reveal decreased PaO2 and rales with diminished breath sounds or possibly wheezing. Cardiac dysfunction and arrhythmias are common. Treatment is aimed at maintaining oxygenation and decreasing cardiac preload with venodilators and diuretics. Contractility may be increased with positive inotropes, and ACE inhibitors may be used to decrease afterload in more chronic cases. Oxygenation is also important and may need to be achieved by either CPAP or mechanical ventilation. Albumin or mannitol may be used to increase osmotic pressure to combat the increased hydrostatic forces. Pulmonary emboli is caused by occlusion due to thrombi of the pulmonary arterial branches and usually arises from clots in the lower extremities. Patients may or may not show the classic signs of pulmonary emboli, which include dyspnea, hemoptysis, and pleuritic chest pain. Most common causes of PE include long periods of immobilization and DVT. Diagnostics include CT scans, as chest x-rays usually don't show emboli, and blood tests such as fibrinogen tests. Pulmonary angiogram, extremity venography, and MRI may be very useful, but cost and time may be prohibitive. VQ scans may be helpful, as well as ECG, to identify associated arrhythmias and ST to T wave abnormalities, atrial flutter, and fibrillation. A Wells score may also aid in clinical prediction of emboli, with points given for signs such as tachycardia, embolization, history of past emboli or DVT, etc. Treatment begins with prevention of DVT with ankle pumping exercise, compression stockings, exercise, and medications. Transvenous devices such as Greenfield filters may also be employed, and heparin therapy is the most common treatment, with embolectomies losing favor. Neuromuscular causes of RLD are spinal cord injuries, ALS, Guillain-Barré syndrome, myasthenia gravis, tetanus, and muscular dystrophies. Spinal cord injuries are either due to trauma or by pathology, and if in the cervical spine region can result in inspiratory and expiratory muscle paralysis and inability to cough. These result in hypoventilation, hypoxemia, and hypercapnia, and increased lung infections. Paradoxical breathing may occur if the diaphragm remains intact, but other muscles of breathing are paralyzed. Diagnosis includes spinal x-rays, myelograms, CT scans, and MRIs. The patient may require short-term or long-term mechanical ventilation and pulmonary toilet. Amyotrophic lateral sclerosis, or ALS, is a progressive degenerative disease that involves both upper and lower motor neurons. The average life expectancy is 2 to 5 years from diagnosis, as the muscles of swallowing and breathing weaken and waste. Patients may exhibit decreased volumes and capacities on PFT, with RV equaling FRC, if no active expiratory muscles are functioning. Patients will exhibit difficulties moving extremities, swallowing and breathing, and diminished breath sounds. There is no cure and physical exertion is not encouraged, but getting the patient out of bed and mobilizing as able is encouraged. Diaphragm pacing may be employed when respiratory muscles fatigue and may delay the need for BiPAP or mechanical ventilation. Guillain-Barré is a demyelinating disease of the motor neurons of peripheral nerves. It is characterized by rapid bilateral ascending motor paralysis from legs to muscles in the face, and approximately 10 to 20% of patients may develop respiratory failure and require mechanical ventilation at some point. Most patients develop GB after a viral illness, bacterial infection, surgical intervention, or vaccination, with 2/3 of patients reporting an acute infection within 2 months and 90% with an illness within the past 30 days. Tests to diagnose Guillain-Barré are cerebrospinal fluid analysis with observation of increased albumin levels with 10 or fewer mononuclear leukocytes, and electromyograms and nerve conduction studies which can be used to show decreased nerve conduction velocities. Myasthenia gravis is a chronic neuromuscular disease resulting from an autoimmune attack on acetylcholine receptors, although the reason for this is unknown. This disease predominantly affects women between the ages of 20 to 40 years old. The acetylcholine receptor sites become bound to IgG, and this impairs normal nerve to muscle transmission. Presenting symptoms are ptosis, diplopia, dysarthria, and dysphagia, and weakness of muscles that involve cranial nerves. Then the descending paralysis continues until it reaches the lower limbs. Approximately 10% develop respiratory muscle weakness requiring mechanical ventilation. Diagnosis of MG includes immunologic testing to detect anti-acetylcholine receptor antibodies, treatment and improvement with edrophonium, also known as tensilin challenge, which works by inhibiting acetylcholine uptake, and electromyography to test for rapidly decreasing amplitude and the motor action potential with repetitive stimulation. Treatments include anticholinesterases such as pyridostigmine or neostigmine to help improve neuromuscular transmission and increase muscle strength, immunosuppressive drugs to suppress the production of abnormal antibodies, and plasmapheresis to remove abnormal antibodies. Thymectomy is recommended for thioma and is used to rebalance the immune system. Tetanus is a neuromuscular disease caused by the neurotoxin Clostridium tetani, which is found in soil and feces and enters via a contaminated wound. It causes muscle rigidity so severe it immobilizes the chest wall, resulting in asphyxia and death. The best treatment is prevention with a tetanus vaccine, but prompt and careful wound debridement and administering tetanus antitoxin before the toxin binds to the ganglioside membranes and the nerve synapse is important. Supportive care includes maintaining an airway and ensuring adequate ventilation. Muscular dystrophies may also result in RLD and are caused by genetic factors, with Duchenne's being a sex-linked X chromosome recessive disorder that only affects boys. Other dystrophies include facioscapulohumeral, limb girdle, and myotonic dystrophies. Electromyography, muscle biopsies, and serum enzymes such as creatine kinase MM and MB are used to diagnose these diseases. Specific to Duchenne's is amniocentesis prenatally to analyze DNA. Treatment is supportive with prevention of respiratory infections being a primary concern for respiratory therapists. Lastly, musculoskeletal causes of RDL include diaphragmatic paralysis or paresis, kyphoscoliosis, ankylosing spondylitis, pectus excavatum, and pectus carinatum. Diaphragmatic paralysis or paresis is characterized by loss or impairment of motor function of the diaphragm due to a lesion in the neurologic or muscular system, such as bronchogenic carcinoma, or damage to the phrenic nerve due to thoracic surgery. This leads to the diaphragm being pulled up and the anterior ribs inward and results in alveolar hyperventilation, microatelectasis, VQ mismatch, alveolar collapse, and hypoxemia. Diagnostic tests include PFTs to assess flow rates, fluoroscopy, CT scans or ultrasound, or chest X-rays which shows an elevated hemidiaphragm. Electromyography can be used to directly assess the muscle electrical activity. The diaphragm contractile force measurement is a direct way of measuring transdiaphragmatic pressure by using a probe with a double balloon, esophageal and gastric. Normal transdiaphragmatic pressure is greater than 98 centimeters of water, but pressures below 20 centimeters of water will present as respiratory distress in the patient. Unilateral involvement usually does not require treatment, bilateral presentation requires mechanical ventilation, and in some with an intact phrenic nerve, diaphragmatic pacing may be utilized. Kyphoscoliosis is a combination of excessive anterior-posterior and lateral curvature of the thoracic spine. Spinal curvatures less than 70 degrees usually show no pulmonary dysfunction, but angles between 70 to 120 degrees show some pulmonary dysfunction, and angles of curvature greater than 120 degrees show severe RLD, and respiratory failure usually shows up as less than 40% predicted in vital capacity on PFTs. Confirmation of kyphoscoliosis is done with chest X-ray and physical exam. Treatment includes Harrington strut bars, orthotic devices, or a combination of the two. Nasal CPAP may be used to prevent nocturnal respiratory failure. Ankylosing spondylitis is an inherited arthritic chronic inflammatory disease of the spine. It is marked by decreased compliance of the chest wall. Some patients develop pulmonary lesions and cavitation. Patients may exhibit dyspnea on exertion, pleuritic, and chest pain. Although there is no cure, patients benefit from exercises to increase thoracic mobility and prompt treatment of pulmonary infections. Tumor necrosis factor TNF blocker may decrease inflammation and pain. Pectus excavatum and carinatum are the last musculoskeletal causes of RDL that we will discuss. Pectus excavatum is a congenital abnormality that presents as a funnel chest with sternal depression and decreased AP diameter. It is shown on PFT as a decreased TLC, VC, and MVV. Usually treatment is cosmetic as no functional deficits usually occur. This slide shows a picture of a 12-year-old boy with the most frequent form of pectus excavatum. Pectus carinatum presents as a pigeon chest with a protruding sternum anteriorly. It is associated with prolonged childhood asthma, and 50% of patients with atrial or ventricular septal defects also show this chest morphology. Again, no treatment is indicated for this condition. This slide illustrates a 13-year-old boy with pectus carinatum.